Thank you so much, Chairperson, and thank you to DRS, Purvi, Manoj for inviting me here today. Thank you, Astra, for inviting me for this particular talk. So good afternoon, everybody. My talk today is about a very clinically important subset of patients that all of us see in our day-to-day practice. And this we're talking about patients with type 2 diabetes alongside with multiple risk factors, more specifically those patients who have 3 and more risk factors alongside with their diabetes. Now, if one thinks about our day-to-day practice, this actually happens in more of our patients than we actually imagine. If you really think about the number of patients you see with diabetes and that extra hypertension or dyslipidemia or age also being counted as one of the criteria right now, or basically obesity, well, that number is fairly high. So let's go a little bit deeper into this, understand why we need to identify this set, understand why we need to manage this set more aggressively than our routine diabetes patient. So the habit for us so far has been, today if I have my diabetes patient who comes into the clinic and this patient turns out to have high cholesterol, I will start the patient off on a statin. And the patient comes the next time and you see that he's had a couple of BP readings, maybe a little higher, and you know that this patient needs to be put on an antihypertensive. You will start off that kind of medication, you'll start an ARB. So basically what we are doing is managing each comorbidity in a silo. What we are not doing is stepping back, zooming out a little bit and thinking that with one extra risk factor, we are not just dealing with 1 + 1 = 2 risk factors. What we are dealing with is actually a multiplicative effect. It is not an additive effect. It is actually a multiplicative effect in terms of cardio-renal risk status. And add to that mix, let's say a third or even a fourth risk factor, let's say if albuminuria, for example, comes into this risk, basically this level of risk becomes actually exponential. Now, this kind of subset of patients, what we need to realize, needs that extra recognition, needs that extra care and more aggressive management also as well. Dr. Dargad, good afternoon. Yeah. So today what my talk is basically comprising of is the need to risk stratify these patients, how we risk categorize in terms of guidelines, in terms of the count of the number of risk factors, how we are managing this cardiorenal risk for these patients with type 2 diabetes with multiple risk factors or by the KDIGO class. What does the ADA have to say about this kind of group? What is the effect of genetics? Does it make a difference to be on genetics versus the innovator molecule? And ultimately, what is our goal for this subset of patients? So moving forward, basically, let's understand that today, what is the need for this risk stratification? Well, today, if I have a patient, let's say these are patients, what I'm showing you in this bar graph, they have been categorized based on their renal risk by KDIGO. So you have a KDIGO low risk, moderate, high, and a very high risk. All of these patients, diabetes control, same, well-controlled patients. But if you look at the second two areas, you're talking about the moderate and the high risk and the very high risk, you know that this group of patients with KDIGO high risk or very high risk is going to have a completely different trajectory in terms of their cardio-renal outcomes over the next 5 to 10 years. The point being over here that the A1C control alone, glycemic control alone is not our job. We need to understand that this set of patients needs special and different care. So now risk stratification in type 2 diabetes is not only about checking the box, checking those 20 boxes, whether I have this risk or have that kind of risk. What we are trying to identify over here is a more vulnerable population amongst our patients with type 2 diabetes. How high is the risk? I remember when I was doing fellowship for that matter, patients who'd already had a cardiac event, who already were in high stages of CKD, we would say, this is a very kind of high risk population. Let's get them into hypoglycemia. We can maybe treat them a little less rather than treat them a little more. But now that entire narrative has changed. Because when we have the higher risk group, a more vulnerable group, given the agents, the intensive strategies, the cardio-renal protection that we have available with us today, our whole outlook on diabetes management and risk stratification has completely changed. So what are the different methods we have available to us today? Well, clinical risk factor assessment, if you really think about it, I think each of us is already looking into all of this. We might not look at the bigger picture, like I said earlier, but no doubt we are looking at the major risk factors: hypertension, dyslipidemia, smoking, albuminuria, age. So these are the risk factors specifically that we are looking when we are doing this kind of assessment. What is the advantage? Well, it's simple, it's rapid, it's guideline-based, and for that matter, it's very, very practical, probably in our clinics, and actually has been endorsed even by the ESC, by the EASC in 2023, and by the ADA in 2024 also. We do have other risk scores, risk calculators that maybe some people are using over here. The UK PDS Risk Engine, Framingham, Recode. This gives individualized risk protection, and there is data about this. But honestly speaking, if I was to ask this audience over here, how many of us are really patient upon patient using these risk calculators? I would say I am a failure itself when it comes to using these kind of calculated scores. Guideline-based risk categories, well, the ESC, EASD, well, which classify risk with moderate, high, very high, etc., are based on history, duration also. We'll talk about that a little later. And then we have imaging, non-invasive testing, like the coronary artery calcium scores, carotid IMT, ABIs, and the biomarkers, HSCRP, NT-proNB, also different methods for the purpose of CVD risk stratification in our patients with type 2 diabetes. So let's look a little more in detail at the guideline-based risk categories. So KDIGO, for example, well, this is a very often used tool incorporating not only EGFR, but also with the addition of albuminuria has really kind of helped us understand the projections, or rather the prognosis for our patients with CKD as well. So imagine today, if I have a patient who's in G3A, let's say I'm sorry, I'm not sure this is working. So let's say a patient EGFR is 55. So this patient, as per this, would fall into a G3A. Now imagine if I had an albuminuria level of 10, which would make this patient fall into the A1 category, which is actually at moderately increased risk, versus an albuminuria level of 450. Directly same G3A, but can go from the yellow to the orange to the red. Prognosis completely and absolutely different. Basically indicating again that risk stratification for this kind of CKD patient who has a completely different prognosis based on albuminuria alone is very important for us to recognize and act upon. Now, what I was talking about earlier, by the simple method of risk factor counting. Now, like we know in India, we are a country where patients come with multiple risk factors for that matter. 80% of our patients are going to be hypertensive, a great number obesity, a great number with dyslipidemia, and then follow the more advanced like CKD, CVD also as well, roughly around a fourth of all our patients. So we are a country who doesn't come with low risk profiles in terms of our diabetes patients. Majority of our patients are going to have multiple comorbidities. We are a multi-morbidity kind of diabetic population in our country. At least 2/3 of our patients are going to have combined comorbidities that arrive in a cluster. My patients will often ask me, oh, I had diabetes, now I've developed high cholesterol, now I've developed hypertension. Well, what I try to explain to them are that these are not conditions that come in silos. They are basically all best friends. One comes in a different form, affecting another organ. So all of these, like we know, tend to come in clusters. And at the same time, at least 1 in every 2 of our diabetes patients will turn out to have more than or equal to 3 comorbidities simultaneously. So if we all think of our clinic practices, if you think back, well, you'll find that all of our patients, age-wise or obesity-wise or dyslipidemia, hypertension-wise, a lot of them falling into this category. If you look even from an age-wise categorization, the first bar showing 18 to 39, so 30% of patients of age 30 and 70% of our patients of age 70 are going to have actually more than or equal to 3 comorbidities existing simultaneously. The sad news is that it's not only about the presence of these comorbidities. So that in itself is giving one level of risk, but 30% of our patients with diabetes have 3 or more risk factors which are out of target. So while having them is kind of conveying one level of risk, having them out of control just exponentially increases that risk again. So what is the point of sitting and counting all of these risk factors? What is it that we're trying to interpret? What is it that we're trying to understand? That the greater the number of risk factors, 3 and more, the higher is the chance of these patients getting an acute MI or of heart failure. If you look at that final statistic, which to me also, when I looked at that number, seemed mind-boggling, type 2 diabetes with 4 risk factors, a 232% increased risk of an MI, a 285% increased risk of heart failure. This is where our patients are going into, and that's why taking cognizance of the number of risk factors is extremely important so that we can take the right action right at the outset. Macroalbuminuria also is very common. For patients with type 2 diabetes with 3 risk factors, macroalbuminuria is present in 7.4% of patients, and make it into 4 risk factors, directly zooming up to a 30% of patients with macroalbuminuria. Now we know that albumin in itself is a mediator and marker, not only for worsening kidney disease, but for cardiac disease in itself. As a result of which, when this is something that crops up, you have albuminuria which is increasing. Again, important to take early intensive action. And again, for patients with this kind of subset, this highest risk phenotype in terms of what I would call it, type 2 diabetes with 3 risk factors plus a 340% higher risk of CV death. I don't think any of us have even realized that. When you have that patient who is older, more than 55, obese, with hypertension, with dyslipidemia, this is the kind of number that we are dealing with. So this kind of patient, let's all understand, when this patient comes to our clinics, the onus on us is not only to get the A1C to goal. We have to look at the bigger picture, because these extremely high-risk patients deserve the best in this era where we have the armamentarium to get these patients, to protect their organs, to delay disease progression, to give them better quality of life. It is our responsibility to give them the right agents to get them to the right goals. So let's understand now, we've talked about the problem. Let's see what are our solutions. What is the evidence in terms of managing this kind of high-risk group? So what we're specifically going to zone in on today is dapagliflozin with the innovator molecule Forxiga, which has an immense body of evidence in the form of what we're going to talk about over here. First is declared TIMI. Of course, we have so many other trials also on the innovator molecule. But what's important to see over here is that in the declared TIMI, what I'm showing you over here are the renal specific outcomes in the primary prevention cohort. So these are not patients who already had a pre-existing disease, but in the primary prevention cohort, as the number of risk factors went up, 1 risk factor climbed up to 2 and climbed up to 3, the renal specific outcomes actually got better and better. So the greater the number of risk factors, the greater was the risk reduction. So imagine for this kind of subset, type 2 diabetes with 3 risk factors, an 80% relative risk reduction where it came to renal specific outcomes for a primary prevention cohort. And I'm repeating that again. The overall reduction, well, you have a 49%, if you look across the entire population used over here, a 49% improvement. But again, the greater the disease risk rather, the greater was the protection. Same thing with the hospitalization due to heart failure. The greater the number of risk factors, again, the lesser were the number of hospitalization due to heart failure, and overall improvement, again over here, of a hazard of a 36% reduction also as well. As far as the KDIGO categorization goes, the use of Forxiga, again, in this high-risk type 2 diabetes population, a 59% risk reduction in the renal composite with the use of Forxiga. So again, over here, classification as per KDIGO, grades, and the greater the risk you have, the better, the greater is the outcomes with that also as well. The same goes for cardiorenal composites with the use of Forxiga, a 64% relative risk reduction for a primary prevention cohort. Forxiga also, and this was just an exploratory analysis, it improved albuminuria compared with placebo. Macro went to micro or normal. So what you're seeing again over here, just the addition of that drug, we're not talking about glycemic improvement, we are talking again about albuminuria improvement, which greatly improves the risk. How much time do I have left? Are we done? Okay, so just one final word over here. The ADA now basically has explicitly given guidelines that for patients who have high indicators of CV risk, more than 55 or all the risk factors that we spoke about, it is not about patients with established CVD or established CKD, but if they have risk factors already, the use of these SGLT2 varieties with proven benefit needs to be started. Just one final line over here. Why is it that the innovator molecule makes a difference? Well, when there have been studies about generics versus innovators, the highest risk groups suffer the most. This has been proved with statins. It's been proved with clopidogrel. Again, bioequivalence requirements of these kind of generics is very, very poor as compared to the innovators. Do our high-risk diabetes patients deserve a substandard care? Bio-creep, which is basically a cascading down of bioavailability as one generic might use another generic as a reference. Again, for our high-risk kind of patients, do we really want to compromise on giving them substandard, unevidenced molecules? And finally, as far as the Indian requirements go, our dapagliflozin, which is classified as a BCS class 3, does not require human studies. It only requires in vitro studies to prove its equivalence. Again, with 650 different types of DAPA brands, do we really want to take a chance on these kind of patients? In short, these are patients with a 340% higher risk of mortality. What we really need to do over here is basically give them the best care in terms of our knowledge and our application. Let's give them, alongside with that, the best kind of molecule available in the class, which is your innovator brand of dapagliflozin. Again, a few slides just saying that it delays the need for cardiologist and nephrology referral, which all of us might have seen. So importance of risk stratification, why we need to focus on this group, why do we need to take a chance on this kind of patient? Let's give them the best. Thank you very much.